Hello and welcome to Hot Issues. This week, we are taking a look at the National Health Insurance Authority and the scheme that it runs. We're going to ask several questions. Is the scheme functioning properly? Are there problems with the scheme? What are the challenges facing the National Health Insurance Authority? Is it true that those who are registering, the members are falling, and so on? These are some of the issues that we're going to try and probe today. Welcome to Hot Issues. Hello and welcome back to Hot Issues. Now, as I indicated from the very beginning, we are taking a look at the National Health Insurance Authority and the scheme that it runs. And we are particularly privileged to have with us Mr. Nathaniel Otoo, who has just been appointed as the acting boss of the National Health Insurance Authority. So you're welcome to the studio.
Thank you very much, Chrissy.
Yeah. How does it feel like being in the seat as CEO of the National Health Authority after Sylvester Mensah?
Well, certainly the shoes are very big to fill. But I've been at the authority for quite some time. I understand the challenges. I've been working with past managements on the issues. And now it falls on me to actually deepen the direction in which we are going. It is challenging, but I think we are up to the task.
What are some of the challenges, the major challenges? What are they?
Kwesi, I would probably flip your question a little bit on the other side, because I probably would just want to say, where are we now? The National Health Insurance Scheme, as of 2014, had 10.54 million people as members. We had close to about 4,000 health facilities providing services. We saw 29 million health insurance claims in a year. About 90% of all attendances at public hospitals and facilities are on account of the NHIS. And for private facilities, it could range up to about 80%. That is what the state has been. But then, do we have challenges? Yes, the answer is yes. And the one that you hear most often talked about is delays in payment to our healthcare providers. As a matter of fact, the healthcare provider needs only one thing. We ask them to provide a service and they want to be paid for it. And when they've not been paid, it poses a challenge. Do we know this situation? Yes, we do. Is it self-inflicted? The answer is no. It is structural. The health insurance scheme, when it was developed in the early 2000s, envisaged that after about 6 years of operation, we were going to have financial sustainability challenges, which means we'll get more expenditure than income. We have tried a number of things to extend the life of the scheme past that. And as a matter of fact, we've been doing this now for 11 years, whereas it was predicted that we'll have challenges after 6 years. I think we've done a little bit of good work to extend it, but now we're at the point where we have to look at ways of restructuring it. I am happy to say that from the highest level of the country, the approval has been given to look at the scheme again and to restructure it. And that is the next phase we are going in.
What is the problem with non-payment of service providers? Is it that when the monies are deducted from the VAT, you don't get the money? Or that what we are deducting, the tax that comes to you, is insufficient? What is the problem?
Well, historically, delays in releases of monies collected have afflicted the scheme right from inception. So it wasn't a recent development. But I'm happy to say that as of this year, in the first half, the Finance Ministry had done quite a good job in releasing funds to the scheme. So the issue of delays in payments or releases for that matter, are no more really that serious. What is serious is that the scheme has grown. It has been overtaken by its own successes. We have a lot of people now enrolled. And what it costs us to run the scheme now is less than what we collect on a yearly basis.
What does it cost to run the scheme?
The budget provided for 2015 was in the region of about 1.2 billion. But our claims payment alone topped 1.2 billion. We are expecting to spend about 1.6 billion on claims. But I'm happy to say that in the challenge that we've had, we've gone to government and they've been magnanimous enough to support us and to fill the gaps. We are going to ask for more. but with the view to getting a structure that we can sustain.
Isn't it that the money you use to run your outfit is a percentage of VAT?
It is a percentage of VAT and also of Social Security contributions.
So when you say you're going to ask for more, where is the more going to come from?
Obviously, health is a very important national responsibility. As a matter of fact, our Constitution prescribes that healthcare will be available to the population. But we do understand and we do accept that we can't spend all our money on healthcare. And therefore, in doing this, we ask two things. Do we need to put in more funds, or do we need to really rationalize what we are providing? Both are true. If you look at how much we are spending on the NHIS per member, on the average, we are spending just slightly, upwards of 90 cedis a year per each enrolled member. In today's terms, that is almost equal to about $23, $24. And I'm using dollars as a reference. When you go to other countries such as the US, the cost per insured person is somewhere in the region of $7,000. Mm-hmm. Are we spending less? It is contextual, and it is what we achieve for the money that we put in. Mm-hmm. In this country right now, as you know, we face what we call a double burden of disease. In the past, Ghana's biggest problem was malaria, dysentery, typhoid. All these are, communicable diseases. But then, currently, a new phase has come in where we're facing non-communicable diseases, cancers, strokes, hypertension, diabetes, and so on. These are extremely expensive conditions to manage. And it will surprise you that it costs us about upwards of 15,000 Ghana cedi to manage a cancer situation, whereas it costs us just about 12, 13, 14 cedis to manage malaria.
But are cancers on the list of diseases covered by the scheme?
They are, but not entirely. We do not cover prostate cancer. And sadly, we do not cover childhood cancers, which actually have a better rate of success after treatment. We are having discussions to see whether these can be included. But one thing we remember is that as we add to the package, our costs go up. And it's really, in the health sector, it's an issue of priority setting, as it is in all spheres of national life. And we were going to use this new process to try to set priorities and to see which are those conditions that we should manage. Let me paint a very small picture to you. In Ghana, the distribution of healthcare facilities are not even. Mm-hmm. Those who live in urban areas are better to get better services and more access than those who live in the very rural areas. You go around the country and you find out that a lot of our compatriots receive their healthcare at very small primary facilities. And sometimes when they get even a referral to a bigger one, transportation is a problem. Mm-hmm. So the question we do ask is, are we distributing the pie equitably? And why is it that when I live in an urban center, I should get better services than somebody living in a more rural area? These issues have to be all addressed.
Which are the cancers that you don't take on board?
We don't take on board prostate cancer, which is a male disease, and we don't take on also childhood cancers, and I said unfortunately. Mm-hmm. But I am all for getting childhood cancers. Are those just the two cancers you don't take on board? Those are about the two, but there are other cancers. As a matter of fact, let me put it this way. Our benefits package is what we call an exclusionary benefits package. And what it says is that all cancers are excluded apart from cervical and breast cancer. So as a cancer-covered product, we have only cervical and breast cancers.
Now, beyond cost, are there any other reasons why?
Oh, yes, Chrissy. When you take a scheme such as ours, it has a very, very serious basis on which it runs, a very serious infrastructure. And there has to be linkages in the system. Today, one of the things that affects us a lot, and our members complain about, is the quality of services they get. Mm-hmm. And when you talk about quality of services, there are two aspects. There's what we call the perceived quality, because when you sit across a health professional, you will perceive the quality you are getting, but they know the technical quality that they're giving you. So perceived quality includes, for example, were you greeted at the hospital? Was the nurse polite to you? Were the washrooms clean? Did you get an explanation for the treatment? All those goes to feed a perception. But in reality, when we come to technical quality, It is about following laid down standards and protocols and procedures. So the Ministry of Health has laid down procedures and guidelines safe for treating malaria. And when I'm judging technical quality, I measure those standards against what was actually done. On both fronts, we do have problems. Sometimes just because of human attitudes, our members are not happy. But at other times also, we see where protocols have not been followed. And we see this in our clinical audits. But to say that a large majority of our providers are doing a good job.
What other diseases are not covered by the scheme?
I won't be exhaustive, but I'll mention some. We do cover opportunistic infections for HIV/AIDS-related conditions, but we do not cover antiretroviral drugs.
Opportunistic infections meaning tuberculosis?
Yeah, if somebody has HIV and they have tuberculosis, we will not cover tuberculosis because there's a program for tuberculosis. But if such a person has malaria, we'll cover it. If they have, typhoid, we'll cover it. Anything else apart from providing the antiretroviral drugs.
What about others?
Well, we don't cover
dental care.
We do cover dental care. We don't cover dentures. We do cover eye care. We do not cover glasses. We do cover, areas in which there are already programs running. So I mentioned tuberculosis. That we do not cover as well. In the past, we did not cover family planning. By the new Act of 2012, we are planning to include certain aspects of family planning in the NHIS.
Which aspects?
Well, when it comes to male condoms, by what we are discussing, they will not be included. But we are going to pay for the services that are rendered with products that are offered by programs. So, for example, some donors provide injectable solutions, but they don't provide the labor cost that goes with implanting the injectable. We are going to provide that.
What about female condoms? You just mentioned male condoms.
It's not on the books at the moment because it's what we call a commodity. Really, the NHIS is not going to cover commodities because there are programs for covering commodities. But I know some of these programs will run out with time. And as I said, in the restructuring of the NHIS, we should look at all these. The analysis showed that when you look at family planning and look at it properly, in the end, it might provide benefits to the NHIS and the country as a whole. Because, for example, if you have an unwanted pregnancy, it does cost money to manage, but also it becomes a burden on whoever is bearing the child, and those can be prevented.
Now, how many schemes are there? How many schemes are there?
I will take this opportunity, Chrissy, to address the issue of schemes, because we had schemes prior to 2012. Prior to 2012, we had 145 health insurance schemes which were incorporated under the Companies Act of Ghana as private companies limited by guarantee. At that time, what the NHIA did was only to supervise their operations and also to remit to them funds for their operations. These schemes at the time had 15 members as their boards, constituting their boards of directors, and by a simple calculation, we would have had about 2,000 plus board members in this scheme, which is beautiful. But there were challenges with coordination as well as challenges with implementation. And in 2012, a new law passed, Act 852, which sought to consolidate all these disparate schemes to bring about a scheme of a national character. Now, I'll give you an example. Within the same NHIS with 145 schemes, if you went to Scheme X, their ID card was different from Scheme Y. So we had 5, 6, 7 different ID cards, and you couldn't even synchronize. So whereas some ID cards were capturing age, others were capturing date of birth. So it wasn't really a unified system, and we saw it fit to try to unify these things right from 2008, and we've been doing it until today. So today, these schemes have all collapsed into one national health insurance authority, running one national health insurance scheme, for which we are speaking about today.
So there's only one scheme today.
There is only one scheme.
What about the mutual health insurance scheme?
The public mutual health insurance schemes, which were doing the NHIS, have all been dissolved under Act 852. The Registrar General has issued the notice of dissolution and has actually given us a vesting assent which has vested all those schemes and their assets into the National Health Insurance Scheme. Currently, we have 165 offices around the country, and we have 10 regional offices. 155, and 10 regional offices.
What about the claim that the numbers of people registering is falling?
We've had to answer this issue over and over and over again. I remember the very interesting research done by Oxfam as far back as 2010. At that time, they raised some very salient points, and we considered them. But we had already started looking at our numbers. The NHIS really started implementation in 2005, though a few schemes had established in 2004. And what we did was to accumulate the membership data because it was right to do so at the beginning. Mm-hmm. For some schemes, they had not even started offering services. Mm-hmm. And coming up to 2008, we found out that the methodology was not right. Finally, in 2010, we changed it. And that is adequately captured in our 2010 and 2011 annual reports. If you permit me, I'll just paraphrase from these reports. What the report said was that prior to 2010, our membership was captured cumulatively. And I assure you, Chris, if we had considered that option and continued with it, by now we would have had more members than the population of the country. And that would be absurd. So it had to change. And changing to what we call an active membership, which means somebody who has a card that entitles them to service, rather than anybody who has ever registered in the NHIS, which was the old method.
So that the difference is that now, when we talk about registered members, you're actually counting them one by one.
We are counting people who have a card and tomorrow can go to the health.
So you're not saying that 20 people registered last year, this year 40 people registered, and therefore you have 16
No, we are not saying that anymore. Okay. And let me say that if you look at an analysis from that point, from 2010 when we adopted the new method until today, we've only been seeing a growth in membership and not a fall. And to just, postulate that there is a fall is not really right. As a matter of fact, in 2014, we had 10.54 million members, which is the highest since the scheme was established. And let me say that under our new membership registration system, some call it biometric, but we call it instant card issuance, we register 180,000 people every week. Under the old method, which is now only applicable in one region, which is the Western region, we register close to about 18,000 people. So overall, the scheme is registering on a weekly basis about 200,000 people.
Hello and welcome back to Hot Issues. We are looking at the National Health Insurance Authority and the scheme that it runs. And we're exploring all the challenges that it faces. And we are happy to be doing so with Mr. Nathaniel Otoo, the Acting Chief Executive of the authority. So there's a claim that your claims are rising. Is that true?
Chrissy, that is true. From a very paltry sum of about 500,000 Ghana cedi in 2005, our claims are now topping, we believe this year, about 1.6 billion cedis. You can see the trajectory. It's the result of many factors. One of the factors which is really, is a no-brainer is the fact of inflation. And so a claim that cost 1 cedi in 2005 will no more cost 1 cedi. But there are other things that we have to look at. One, growth in membership. Whereas we had, just slightly south of 1 million people in 2005, now we have 10 million plus, moving on to 11 million. They will obviously consume more services. The second thing that we look at, and it confronts every scheme of this nature, is moral hazards. When we say moral hazards, it means the risk that our own staff pose, the risk that our health providers pose, the risk that our members put, and all the environmental risks with health insurance.
Risk?
Yes.
What are you talking about when you talk about risk?
So when I talk about risk associated with a member, I'm talking really about abuse of the system, impersonation. So somebody...
Corruption of the system.
Exactly.
Okay.
I tend to call them risks. Let's say that. But
you see how language is sometimes problematic. Yeah.
It is problematic, you see. If you talk about fraud, I'm a lawyer, so I understand fraud in the terms of it's being proven. Mm-hmm. Okay. But anything that has a semblance and leads to it is a risk that we have to manage. And when we talk about, the member, in some situations, you see somebody going to a healthcare facility 2-3 times a day. Why? Because they're not paying for it. The state is paying for it. And sometimes they go to facility X, they are not satisfied, so they go to facility Y. It is all a check drawn on the NHIS. Now, some go, they collect medicines, and they store them up, or they simply give them to people. These are realities. They do happen. We also have risk at the point of service delivery at the health provider, provider's point. And let me say that this is not an indictment on our healthcare providers. A lot of them are honest and they work hard. But you have bad nuts within the system. And what they do is to create claims that are not justifiable or sometimes non-existent. To be able to deal with this problem, a lot of solutions have to be put in place. IT is extremely important. You can imagine, Kwesi, navigating through 29 million claims. I don't think you're going to see where one claim is. And the only way is to have a robust IT system that allows us to analyze, to trend, and to sort of do some analysis. Now, the second thing over here is to have a robust system of going back to claims that have been submitted and also ensuring that they are justifiable, which we call clinical audits. And you've seen in the newspapers recoveries that have been made, some arrests, prosecutions, and so on. Thirdly, we are looking at the issue of how we actually adjudicate those claims. When we had district mutual health insurance schemes, the capacity was really very, 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 very poor. Some of the people managing claims did not have the right skills. You had 145 points at which claims were being managed, obviously with challenges. What we're trying to do now is to consolidate claims management and put experienced pairs of hands to deal with them. But at the same time, we have to go electronic. So we started an e-claim system. We intend by the end of next year to have enrolled about 160 facilities. Currently, we just have about 60. Now, with all these together, and let me say that also our staff are risks. So if a member of our staff does something that takes away money from the scheme, it is also a risk that we face. And so in all that we do, we try to bring in systems that minimize these risks. They can never disappear. If you look at the health care fraud industry in the U.S., it is a $27 billion industry where people just create claims, milk the system. We are not an island. We deal with human beings. Some things are human nature. What it is that the systems must put in blocks, by not allowing these things to happen, or at all to minimize them and their effects as we go forward.
What is the size of what you call risk?
It is currently anecdotal. But if you look at what is the experience around the world, healthcare fraud is anything from 7 to 10%.
But you've done clinical audits and so on. What have you found?
We do find a number of things. Our clinical audits are structured.
I'm talking about the size.
The size. Let me just correct this question. Clinical audits are not only to recover money. They are also meant to ensure that standards are followed. And our clinical audits are structured into 12 categories. I might not mention all of them, but one of them is inflation, say, of medicines. For example, that for, let's say, a certain condition, you have to give antibiotics, maybe 15, 16, 18 for the episode. You find some providers giving 100. Some might say it's an error. It could well be, because sometimes it's not the prescriber that writes the claim, it's a transcriber. So granted that happens. But there are clear fraud situations, and we have prosecuted some of them. There are a number with the police still undergoing investigations. I'll mention a very simple one. One we had in one of the regions was a provider, a specialist for that matter, working in a public facility and owns a private facility. And you find out that the claims from the public facility get channeled into the private facility constantly on a monthly basis. Now, the question that you ask is, how come that trend occurs? And
can we understand this properly?
So,
how do claims from a public facility get channeled into a private facility?
Fantastic. All you need
really, what is happening?
All you need to know is he has the card number of the patient, the NHIS card number of the patient.
Mm-hmm.
And so that card number just gets transcribed to the private facility, and a claim is created.
So two claims are being made.
Exactly.
One from the public facility and one from the privately owned facility.
Okay. Where service has not taken place. Now, we did manage to pick up these, and we've picked up a number of them where they are grave and don't merit administrative action. We actually hand them over for prosecution. Now, those are the instances and those are the situations that are really worrying.
Mm-hmm.
And as you may know, Kwesi, if you don't have an interconnected system, how would you know that a claim has been submitted here and there?
Mm-hmm.
Those are the things we are working towards right now. Now, to come back to you, and I know you sounded quite astonished, I don't think everybody is in there, in the health sector to provide services that please our clients. Most health providers do, and I really congratulate our providers who do a good job. But there are a few, miscreants who create problems for the system.
Now, if you see medical specialists or hear about medical specialists, you put them on a certain pedestal.
Well, I still do put them on the pedestal.
You wouldn't think that any of them is fiddling with figures and stealing money from national health insurance, would you?
Because majority of the claims we see are genuine claims. And I would say again, when you see your next healthcare provider, adore him or her because they do a great job. But there are few who don't actually stick to the ethics. And I think their colleagues don't like that, and they will give them up at any time.
You indicated that delays in payment of claims have been substantially reduced. How substantially?
Until May this year, it was really, really challenging. And again, let me explain this basically, because sometimes you'd just hear a story in the newspaper that we owe providers 7-8 months. Let me put it in perspective. The health insurance law envisages that when a provider provides service, they submit their claim within a month of provision of service. Now, when we did our analysis of a sample data that we have, 41% of our providers submit their claims in the first month. 75% would have submitted it in the second month. By the third month, 93% have submitted. The rest 7%, they range between 3 months to 8-9 months. So there are delays on the part of a few providers. When they have submitted their claims, we have 2 months to pay. So by the law, there will always be a 3-month delay of claims payment from when the service is rendered to when the money should be received.
In some instances, 5 months.
Exactly. So when somebody talks about 5 months, it's not 5 months over and above the 3 months. It is 2 months over and above the 3 months. But they put them together to say we owe 5 months, which is true. We do owe.
But when the service provider submits the claim after 3 months,
yes,
and is paid in 5 months, there's no delay, is there?
Technically speaking, Kwesi, yes. Because by the law, if we were going to go strictly accordingly, we should reject that claim. But we also know that we can't be unfair to other people because we've also not paid them. So we don't enforce that strictly. Mm-hmm. When you delay and you bring it in, really that delay is your own cost. And if you have a facility and you want to submit your claim after 9 months, really, Kwesi, we can't push you to do it earlier. Mm-hmm. But when they've submitted, we do our best and try to queue the claims to bring everybody up to the same speed. Mm-hmm. We do have challenges where a few places have delayed, but when we see that, we try to prioritize to bring everybody to. And let me just say that as we speak, we have done payments to our providers until the month of February. And I say this with a caution that not everybody would have received their claims for February for various reasons. Mm-hmm. Some being delays in their own submission, others being delays on our part. But when we say we've paid through February, it means a vast majority of our providers have been paid. If there are outliers, we take them, we mop them up, and we deal with them. We are getting ready to pay March, and we are starting this week. We don't expect to finish this week because we expect still some funds to be released. But I believe that in 2 weeks from now, we would have started doing substantially on the part of claims payment for March. Now, you'd ask, if we paid March, what is the gap? Services that have been rendered in July have been billed for by a number of providers. Mm-hmm. So, strictly speaking, if that service has been billed, it should be paid around, October. Now, for services that were rendered in April, it's April, May, June, July. We have delayed a month. So we are about 2 months behind. We have had a very serious engagement with the ministry, and the ministry is too eager and very eager to work with us to make a case for funds to clear these arrears so that our healthcare providers will have a little respite to provide services to our members.
Welcome back to Hot Issues, and we are looking at the National Health Insurance Authority and the National Health Insurance Scheme. And we're looking at its challenges and trying to find out if it could work much better in our collective interest. And we're in conversation with Mr. Nathaniel Otoo, who is the acting boss of the authority. Now, sir, what can be done internally within the authority to enable it to deliver?
I think so. Because you made a statement or you used a word which really enthused me. You said to improve. The process that we are engaged in is one of continuous improvement. It has never been better one time before the other. We aim to get better. Now, you ask what we do internally. We have a lot to do. Are we the best, most efficient institution? I say no. We do have our own challenges. And if we got better, it will be better for all of us. Now, internally, some of the things we are doing are not major. They are simple, but they have big impacts. And I'll tell you one thing. In the last 1 month, we've been around our district offices, and we have seen that the process of registering a member costs money unnecessarily. And how does it cost money? When a member shows up to enroll, we'll take all their personal details on a sheet of paper, and then we hand that sheet of paper over to the registration agent, who transcribes that same information into a computer. Mm-hmm. Paper for registration costs us about 4 million cedis a year. Now, do we need this step? Our view is no. We can do away with it. And how do we do away with it? We do away with it by just getting the member to sit right across the registration agent and have their data inputted without paper. So, Kwesi, if I manage to cut paper as I intend to do, I free up 4 million cedis for doing other things. Mm-hmm. Now, not only do I free up 4 million cedis, those people, staff who start transcribing and writing people's data on paper, are free to do other services or render other, assignments. Now, what do we want to do?
You could also retrench them.
Well, yes, in a way.
Is that an active option?
It is not an option at all, because we see there are parts of our operations which we have neglected. When a member of the NHIS shows up at a health facility, in most facilities they are left without help. They don't know how to navigate the system. So they show up and they are on their own. We have to be available at the facilities to help them navigate the system, and when they have complaints and issues, we should help them resolve and deal with them. So what we intend to do is to take these freed up staff and deploy them to healthcare facilities to work with the facilities to make their work easier, but also to let our clients have a better experience at the healthcare facility. As you know, our healthcare facilities in Ghana have been inundated because of the NHIS. Some have seen, attendance rise 50%, 100%, which is a good thing because people should get healthcare in the country. So that is on one side. You see, the other part is that healthcare is extremely technical. And in healthcare parlance, we say there is asymmetry of information. When we talk about symmetry, is one thing looking like the other on different sides of the plane. But when you talk about asymmetry, it is one thing looking unlike the other on the other side. In healthcare, the healthcare professional has more information than you or me. They have learned and studied for 7 years or 8 years and have done their housemanships and specializations. Who am I to challenge a doctor or a nurse, based on their professional advice? I may be able to do so, sometimes wrongly. But then there are issues that we as citizens can negotiate. And the health insurance scheme has a benefits package which says this disease is covered. This investigation or lab services are covered. These medicines are covered. When a member shows up at a facility, they are clueless. Our medicines list as 520 plus medicines, all with weird names, which people can't even pronounce or comprehend. And I show up and I'm told it's not covered or it's not available. How do I negotiate it? And so our view is to put some power in the hand of the citizenry. How do we want to do that? We have started talking to the IFC, the International Finance Corporation, to help us with developing mobile applications where, just by entering a medicine or a procedure, you know whether or not it's covered. Of course, it's not something that all our members can use, but in a large measure, it puts some power in their hands to be able to negotiate for what is their right to get under the NHIS. So we're thinking about that as well. Thirdly, if you take the NHIS, it's a huge organization. We have 160 offices. What do? Each and every NHIS vehicle has a tracking system where we are able to call to account every user of a vehicle. Have you overspeeded? Have you exceeded your range that you have to go to? So if a vehicle is in Boku, we have put a ring fence around it. It cannot drive to Bolga except by permission. These are little things we do to improve efficiencies in the system, but we have a lot more to do. But again, Kwesi, let me add...
Just a very, very, very quick one. Yes. And it's about the quality of drugs that are available under the scheme. Is it true that the quality of drugs available under the scheme are the cheap and sometimes ineffective drugs? And briefly.
Kwesi, I think, in your capacity as a seasoned journalist, you've seen how medicines are dispensed and sold in our sub-region. Nigeria, Ghana, there are, fake medicines on the market. They are not necessarily generic medicines, and I'll come back to that. Fake medicines can be anything. So to say NHIS medicines are fake is
not
wrong.
Fake. Cheap. Yeah.
Well, let's
and sometimes ineffective.
I'll come this way, Kwesi.
Because of the cost.
The law says, the NHIS law says that we shall use generic medicines where branded the branded medicines are no more available. That is to say, and let me explain it. When any pharmaceutical company develops a medicine, they own the patent. It's a legal issue. Under the WTO rules, World Trade Organization rules, there's a section called TRIPS, Trade-Related Aspects of Intellectual Property. The TRIPS say that when you have invented a medicine, you have the right to harvest your invention for, say, 20 years. Now, after 20 years, anybody can manufacture that medicine, not under license. They are free to manufacture it because it is deemed that you would have reaped all your benefits. Now, when that time passes, medicines that are developed by other people using the same formula are called generic medicines. Now, the NHIS by law allows the prescription of generic medicines, which means medicines outside patent. That's all it means. Generic,
they can be as effective as the originals, but then they cost less.
Correct.
Thank you very much. Yes. Thank you very much for coming. Yeah. Thank you. Well, it's been a pleasure talking to Mr. Nathaniel Otoo, the acting boss of the National Health Insurance Authority, and we've been exploring all the challenges facing the organization. I do hope that all of us have picked up a thing or two, and we have a better understanding of the scheme and of the authority now.